As we talk about communication disorders and hearing loss specifically, I like to go back to this model of spoken language communication that was put forward by Denz and Pinson in 1982. And I like it because it really encompasses every component of spoken language communication from beginning to end. At the very beginning, we have factors that are related to the speaker, the person who's putting out the utterance. In this case, that would be me. So issues that are related to the speaker are things like, how fast am I talking? What kind of language am I using? Am I producing my utterances correctly? Is my articulation good or is it poor? All of that information is then put out into the air. And as I speak my utterances, I'm displacing air molecules in the air around us, and that sound is traveling to you. So the medium at which the sound is being presented is really important. Sound can travel through air pretty well, but it can't travel through water very well. So we can hear pretty well because we have this air-filled medium, but if we were all underwater, everything you heard would be pretty muffled. So the air is pretty important, and how much noise there is around us is also important. So are there things happening outside that are distracting us or creating so much noise that it's pulling away from what I'm saying? And then also how much echo there is in the room. If there's a lot of echo, all that reverberation can bounce around and actually mask out what I'm saying. So this is a pretty nice room. The walls are pretty sound. There's a lot of reflective surfaces, so there's some echo, but it's still a pretty good medium. So the speaker puts out sound waves, speech, that travels through the air and is eventually received at your ear. And your ear takes all that information up to your brain to process the sound. Now hearing, as it is a pretty passive activity. You're hearing me no matter what. Even if you're looking at something else and thinking about something else, you can still hear me. So it's occurring no matter what else happens. And as I'm talking, you can probably hear the projector, maybe hear other people rustling, things moving around you. So it's a passive activity. Listening is an active activity. It's something I have to pay attention to. I have to process sound and devote some of my cognitive resources to processing what's being said. So there's this bottom-up sensory input that's going to your brain, but then this bottom-down, this top-down processing that you're applying to the information that you're receiving. So as you hear me, you're using all of your cognitive resources to make sense of what I'm saying. Hopefully it makes sense. So there's this bottom-up processing and this top-down processing. And I bring all of that to this environment and to this context. So what I know about language affects how well I can process sound. If I was not a native speaker of English, it would take me longer to process what was being said. So the listener brings a lot to this whole environment. And that's key for what we're going to talk about today, because we're going to talk about some interventions for people with hearing loss that involve both the listener and the speaker. When we measure hearing, we plot it on what's called an audiogram. It's a graph that reflects how well we can hear sound. And the graph is organized so that pitch is along this axis here, going from low pitch to high pitch, like the keys of a piano. And loudness is on this axis here, from soft to very loud sounds. The pitches that are represented are important because these are the pitches of speech. The human ear can hear, between 0 and 20,000 hertz, but speech really only occurs between about 250 and 8,000 hertz. So we don't really have to measure how well you can hear 16,000 hertz or 20,000 hertz because it doesn't really impact your ability to process speech. But we do want to measure these pitches because these results will then tell us how well can you hear the various speech sounds in our language. So low-pitched sounds are things like vowels, like ah and oo, and high-pitched sounds are more consonant-related, and sounds like S and T and F. So if we plot your hearing levels on this graph, we can then make some broad interpretations about what speech sounds you can hear and what speech sounds you can't hear. This graph is also nice for displaying the sounds in our environment. So we can plot how loud and what kind of pitch environmental sounds are, like the sound of a vacuum, the sound of a motorcycle, and really loud sounds like airplanes going over top. When we plot hearing levels, we do left ear and right ear. And a good way of looking at this graph is to plot the left ear as an X and the right ear as a circle. So here we can see the left and the right ears plotted on that audiogram. And on this axis, I've put in the levels of hearing severity. So anything that is above 25 dB, 25 decibels, is considered normal hearing. Below that, we have the different ranges of hearing loss, from mild hearing loss to moderate hearing loss, moderately severe, severe hearing loss, and then profound hearing loss. To illustrate those different pitches, I'm going to play a couple of them for you. So here is a low pitch sound. This would be 250 hertz. He said with great confidence, if he can get it to play. Here's 500 hertz. 1,000 hertz. Oh, you stinker. Let's do this. Uh, 2,000 hertz. And 4,000 hertz. If any of you couldn't hear that, you should come see me later. So those different pitches broadly represent the pitches of speech. Every audiogram is a little different. No matter which institution or clinic or hospital you're working in, they may plot their results just a little bit different. This is an example of an audiogram from the Mayo Clinic. And again, we have pitch along this axis, loudness down this axis, and the different ranges of severity plotted on your right-hand side. This would be an example of somebody that has normal hearing in both ears. I can see the left ear in the X and the right ear in the circle. And this one is also color-coded so that red is right and blue is left. This person has levels that are well above 20 dB, so we know that their hearing is normal in both ears. Here's another example of an audiogram, but now the X's and the O's are below the normal range, and these are in the range of moderate to mild hearing loss. So this person has hearing loss in both ears, and enough hearing loss that it would affect how well they can hear the speech sounds in our language. So this would be somebody that we would want to intervene with. And if we couldn't intervene with medical treatment, we couldn't fix it with antibiotics or surgery, then we'd want to look at other forms of intervention like hearing aids, cochlear implants, or assistive listening devices. And that's where an audiologist comes into play, is when we can't fix hearing loss with medical intervention, then we fix it with non-medical intervention. That's a bit confusing because a cochlear implant is obviously a medical intervention. The surgeon places the device, but then all the post-operative work happens by the audiologist. I'm going to talk about 4 broad categories of interventions today. The first are clinical trials, things that look at how well we can remediate hearing loss through work with molecules and gene therapy. The second are hearing aids. Third, cochlear implants. And then fourth, I'm going to talk about some modifications that we can make to the speaker that will improve how well a person can hear. Broadly, there are clinical trials going on all over the US and all over the world. Drug companies that are looking to restore hearing through pharmaceuticals. You can imagine that this is a pretty important industry and that the drive to find drugs that can remediate hearing loss would be hugely beneficial. We have a growing and aging population of which hearing loss is the 3rd most common disorder. And then there's hearing loss that occurs in childhood. And hearing loss that occurs congenitally or at birth is the most common disorder that is present at birth. So about 3 per 1,000 children are born with some form of hearing loss. If we could remediate that through drug therapy, that's a huge industry. There's a lot of money there. So many companies are really focused on trying to develop and bring to market a drug that can fix hearing loss. The first area of clinical trials are related to molecular therapies. Molecular therapies aim to improve hearing by either slowing down the age-related changes to our auditory structures or somehow making our inner ear more resilient to damage. Last time you learned about the structures of the inner ear, that snail-like structure, that's the cochlea, and you learned about the hair cells that line that structure. If we could make those hair cells more resilient to noise damage, then people that were in excessive noise wouldn't have hearing loss as often. If we could make those hair cells more resilient to the changes that happen with aging, then perhaps hearing loss wouldn't occur as often as it does. So molecular therapies generally aim to make the inner ear more resilient and keep off the effects of noise and aging. Gene therapy is a line of research that looks at restoring hearing for people who have genetic-related hearing loss. Genetic-related hearing loss comes from your family. So if there's hearing loss in your family and it's passed on to you, gene therapy could be used to help restore those hearing structures. So if we knew that there was hearing loss in your family, then you could use gene therapy from a very young age to keep off those effects of family-related hearing loss. Stem cell therapy would be used to help regrow damaged or missing hair cells. So in that case, stem cells would be introduced to a body's system with the intent of helping the structures in the cochlea regrow so that they would be functioning hair cells. In my previous career, we were involved in some clinical trials looking at molecular therapies to help keep off the effects of age-related hearing loss. That study came very close to bringing a product to market, but we failed to produce significant results. So we showed that some people had improvements in their hearing, but the improvements weren't significant enough. So at this point, there are no drug trials that have been successful in restoring hearing. I am certain that we'll see some form of drug to treat hearing loss in our lifetime, but what it will look like exactly, which form of these it will take, is still unknown.